Good afternoon, everyone. My name is Reg Joseph. I'm the CEO of Health Cities. I'd like to welcome you all to this afternoon's conversation and allowing us an opportunity to present to you the Home Health Monitoring Initiative that's been led by the Central Zone for the Primary Care Networks. So thank you all for being here this afternoon. We were going to be starting off with Jen Tessenwitz from Red Deer PCN. Unfortunately, she had a personal issue arise and she's not able to join us today. And so Chris Carvalho, who's been involved with the project through Health Cities, has graciously accepted to pop in and provide a little bit of the update that Jen was going to provide us. And I will kick us off this afternoon. So again, thank you all for being here. Health Cities, as some of you may know, is a nationally incorporated not-for-profit organization really focused on driving new technology platforms into healthcare delivery, and primarily in primary care. The reason being, as many of you know, Canada is falling behind other jurisdictions in terms of our healthcare outcomes and our health system performance. And a lot of that has to do with the fact that we are not putting enough resources into primary care. And so one of the ways that we're looking at doing that is how do we stretch the resources that we have by adding in innovation. And so have been working with the Central Zone here for the last couple of years on a very exciting project related to home health monitoring. And we will share with you that project this afternoon. So Chris, if I may, I'd like to pass it off to you to give sort of an overview of the project.
Yeah, great. Thank you, Reg. So as Reg said, Jody, who is the operations lead for Central Zone PCN committee, and really her role is to support the PCNs with common priorities that they have set and work with various partners, as well. So unfortunately, she wasn't able to make it today. So I'll do my best to present the slides that she put together. But as I said earlier, Brooke and Charlotte, you guys are the ones that are on the front lines working with the program. So please do jump in if there's anything else that you'd like to add on any of the slides. So, so Justin, you can advance to the next one. So given the membership, I won't go into, what the PCN is, the Central Zone Committee, other than it is a collection of the 12 Central Zone PCNs, ranging from 5 to 85 physicians, and collectively they serve about 500,000 patients, many or most of whom are living in rural areas. So one of the key factors that we looked at when implementing this is how do you better serve that population. You can go to the next slide, please. So in early in the pandemic, we had some discussions through Health Cities with, I believe it was the Camrose PCN on some HHM activities. And they put us in touch with Jody to take a look at how can we actually take a look at implementing an initial pilot to help provide some services to some of these patients that maybe have difficulty or have barriers in accessing some of these services because of the requirement to receive some of these things from a chronic disease management perspective virtually. So in order to put that together, highlighting the number of organizations and partners, first of all, the 12 PCNs that came together to be part of this, but then also a number of organizations listed here to help build the case, the funding, and the requirements around this initiative. So big partners in Alberta Innovates who've largely funded the pilot, as well as Boehringer Ingelheim, who's been a great community partner in moving this forward. Health Cities, TELUS Health, who's our technology partner, and then AHS works closely with the PCNs as well. We had initially started the project, and then through that also received additional interest from the Ministry of Seniors and Housing to take a look at being involved to better understand how some of these services could be applied to other areas that they support. So not too many projects like this have been able to bring together a large collection of partners, and it really has been a testament to the objectives that each organization is looking to resolve. So you can move to the next slide, please. All right, so when we took a look at the challenge, as I said, the central zone PCN, large and mainly rural geography, large number of patients. Among their patients, the CDM is a key priority to help deliver this in various forms through the primary care networks. And because the PCNs receive funding based on number of patients regularly served, or the panel, by the member physicians, there tends to be fewer resources than urban PCNs, despite serving a large geographic area and population. So especially during the pandemic, was taking a look at how do we help to serve the high prevalence of chronic disease patients with ongoing and limitations in funding. The geographic barriers, the pandemic also contributed to this. So we needed to think about things in a different way. So certainly a big challenge in a time of uncertainty. Next slide, please. So in order to put together a solution, we really looked at, how can we leverage some of the HHM early examples that some of the PCNs had already established, as well as the trends that we were seeing in the industry, to use HHM to enable remote patient monitoring for chronic diseases without the needs for patients to actually visit a clinic. And how can we, allow for predetermined schedules, patients to collect relevant data, and use it as a direct feedback to the clinicians to help monitor conditions, especially during the pandemic. In January 2021, which was year 2 of the pandemic, we initiated this project and received funding to implement 3 waves of the HHM program for up to 500 patients with chronic conditions over about an 18-month period. So a significant investment and undertaking, and involvement from all the PCNs was certainly something that was very exciting. Patients with 1 or more chronic conditions, such as diabetes, hypertension, or heart failure, were selected by PCN CDM nurses, and they were distributed HHM kits, which I'll show in a following slide, that allowed the individuals to either use their own device or a tablet that would also have Bluetooth-enabled biometric devices like blood pressure monitors and pulse oximeters to help with their monitoring of various indicators and conditions. Patients were trained on how to use the equipment and instructed on specific monitoring protocols, and you'll certainly will hear more about the application of that in a primary care setting from both Brooke and Charlotte, who will be speaking next. You can go to the next slide. This is just an example of the kit that was used. So our partners to deliver the technology were TELUS. They have some established HHM practices in other jurisdictions. Certainly a variety of tech in this space, but we wanted to work with a partner that could help with a few things. So one was the managed service, so actually distributing and delivering the kits and devices to the PCNs, as well as someone that was large enough to manage the service levels required to ensure that the tech that we were putting out as part of this pilot was useful. From a Health Cities perspective, anytime we implement these types of tech, we always try to be vendor agnostic. So the data that we're showing is not to validate a particular organization's technology, but rather prove that the model, like HHM in the CDM management, is something that we can actually apply to larger applications or scale as we go. So to start out with TELUS was a great partner, just because they had that infrastructure and process in place, as well as a well-defined kit to ensure that the Bluetooth-enabled devices were going to work seamlessly. So that just gives you a sense of what we were using. So one piece as well, just to note on there, the thermometer was also a key piece, just based on the COVID response, as a way to help patients monitor their temperature and symptoms through that HHM technology. Next slide, please, Justin. So what's unique about this? I think many of you have probably heard about HHM implementations in the past, but I think what really sort of set this one apart is the PCN-based and nurse-led. To our knowledge, this is the first PCN-based HHM deployment that doesn't just focus on one type of chronic condition, but looks at any condition that a patient has from a chronic disease management perspective. So not only was it innovating in the technology, but also taking a look at how do we better use or better support patients with chronic diseases and fit that into the existing programs that the PCNs were already providing as a service. Also, built on an existing collaborative structure. So the PCN committee, through partnerships with the various PCNs that were involved, were able to take the existing programs that each primary care network have in place to support CDM and use this to enhance those services. So as you'll hear, that also allowed for some consistency across, but also some local customization of how these kits were deployed, which gave an extra layer to the uniqueness of the project. In addition to the service itself, I think just showing that we can have a multi-sectoral partnership and the number of individuals across the province, in private industry, working with public organizations, just shows that when there is a collective need and objective, we really can do some great things. And especially during a time of uncertainty during the pandemic, this was rolled out largely in a virtual capacity. So pretty interesting there. And then the key focus of this is just making sure that, regardless of what we were doing or what the tech was, this really needed to be a patient-centered approach, and continuous improvement is always built in. So each PCN continues to refine and monitor and make refinements to the way that they're delivering the service. Next slide, please. So we talked a little bit about the patient-centered continuous quality improvement. As part of our pilot project, as well as the larger initiative with the 500 patients, this really was central to each of those, and making sure that we could get both a robust patient and provider focused evaluation after each phase to ensure that we were meeting the needs of those people that were involved. So here's just a couple examples of some of the comments that we received back. I think the key one is making sure that in this case the patient felt extremely comfortable and supported. There's added benefit. So this really is a testament to the work that the various clinicians and providers did within those pilots. So some really interesting feedback there to show that there was direct impact to patients. Next slide. In addition to the patient-centered focus and the evaluation on the survey side of things, a more comprehensive evaluation has been completed, just to make sure that at the end of these pilot projects, we have some data to show the benefits and use that as a way to make a stronger case for how do we continue to sustain and operationalize these things. So happy to share more results of the evaluation, and we currently are continuing to build on that. But here's just a few stats. As you can see here, diabetes was the most common condition, so about 71% of the patients that were followed by hypertension, and then COPD and heart failure. Quality of life scores and enrollment were lower than provincial norms for Alberta's age 60 years and over, with patients reporting lower scores in 5 domains. And then the exciting part of this is both providers and patients reported positive experiences as part of this. So even with some of the initial findings, we are seeing that there's a positive experience related to the implementation of the HHM solution. As we continue to develop and add to, we continue to make sure that we still have that feedback. So again, a few examples that we continue to get back from the evaluation through each of the different phases. And this just speaks to the power that this actually has and impacts that it has on the patients that are there. So key things like this patient has pushed me to be more responsible regarding my well-being, found it makes you more accountable. So showing that we can actually build some of those behavioral changes to improve the lives of patients is a pretty powerful outcome. And then, as I mentioned, we want to do these pilot projects not only to make sure we're delivering a service, but also to ensure that we're building a case for sustainability and spread. We undertake these assuming that there's going to be benefits, but with the evaluation and with the lessons learned, we really do want to figure out how we can actually move these into operations, whether that's through the PCN group that we worked with or other PCNs, which many of you represent. That really is the hope, is that we can start to share the lessons learned so that others in similar spaces can learn from and build on the activities that have been completed through this initial pilot. So efforts are underway to spread awareness. This is one example. We've also had other webinars and podcasts where we've been getting individuals like Brooke and Charlotte to present on what they're actually seeing from a clinical perspective and the impacts that they're seeing that this has on their patients. So I'm excited you'll be able to hear more about them from them on their experience, and happy to continue to share additional information if we don't go into enough detail here. But that really is the hope, is that we can use the lessons learned to make a stronger case for sustainability and spread. So you can go to the next slide. And that's it from me. So thank you, and I think I'll pass it over to Brooke next to take us through her slides.
Good day, everybody. My name is Brooke Elworthy. I'm an LPN with the Camrose PCN, and I've been the clinic lead for our home health monitoring pilot. Next slide, please. Okay. So for physician and patient engagement, when we originally started out, we took some time to build and draft engagement letters for our physician group, scripts for onboarding our patients, and processes based on the staff resources that we had available to give time to the project. We brought the home health monitoring pilot to our physician group via email for the initial engagement. We sent them info about the pilot, target parameters for the different chronic disease monitoring plans that were available, like demographics, A1C values, hypertension values, really trying to set a target for the types of patients that we wanted to look at. We also explained that if they had a practice facilitator within their clinic, or myself, would help identify these target groups for them, provide them with a list of eligible patients, and then they could review it and approve it for us to call those patients to try and get them to onboard. For the patients, we used the previously mentioned script. So when we called to offer the program, we explained the physician involvement in the pilot project, what it would entail on their behalf if they became involved, and that their doctor thought that they would be a good candidate for the pilot, with the overreaching goal, explaining the overreaching goal of what we wanted out of home health monitoring, being that we were trying to improve access to the rural communities for better health outcomes. Next slide, please. Okay, so to date, Camrose has been involved since wave 1, so roughly that 18-month mark. We've successfully seen 67 patients through the 3-month monitoring program of each wave, and dealt with all 4 of the chronic diseases: diabetes, hypertension, heart failure, COPD. Each of the patients have been dealing with varying degrees of their chronic diseases that have been available. We have been able to identify issues with heart rates, where we have been able to be that middleman to reach out to the doctors and say, hey, something's going on here, and they can ensue further follow-ups and testing to be done. We've identified when different medication management is needed for diabetics. Let's say they have high blood sugars, and we need to look at better control. Same thing with hypertension, COPD, getting those symptoms under control a little bit better. Our team has been able to provide the support for both the patients and the family doctors with the goal of better management and therefore better health outcomes. And I'd like to think potentially decreasing ER visits, although I don't have the stats or the access to that information at this point in time. And maybe that's something we can look at in the future as well. We have seen improvements through the pilot in blood glucose and blood pressure levels, improvements in symptoms of COPD patients, so that everyone can live better quality of lives. We were proud to have been able to provide the support to these patients. We feel that the doctors have been able to better manage their patients, who, if this pilot hadn't existed, would have just, the patients don't know any better. They would have just carried on, not knowing any better about their health. The only limitation that I really saw through this process is how the EMRs that we use for charting and whatnot is not integrated with the specific TELUS Triage Manager platform. And therefore, communication can be a little bit difficult sometimes if you don't have access to their EMR, you're relying on email. Doctors aren't always available for a phone call, right, when us nurses are looking at the different patients and whatnot. So this is something that we are going to be looking at in the future of how this can be addressed. But really, that was the only major limitation that I can see. Next slide, please. So physicians at the end of wave one, we did a small survey up for them, and all the doctors thought that the program had held value for what was trying to be achieved. They appreciated the nurse monitoring team and how they have helped their patients better self-manage their conditions through the support and education and monitoring. We also found out that they did want to see a little bit more feedback from the monitoring team through the process. So in the second wave, we changed it up a little bit, and I would send them an email giving them a brief synopsis of each of their patients that was involved, just so that they could know if we hadn't reached out to them, you know, regarding a specific issue, you know, where their patient was at, how they were doing, that sort of thing. And then regarding the patients, we found that for the most part, they really, when I go through the process, I have seen the patients at initial setup and when they're bringing their equipment back to us. And, you know, I just talk to my patients, ask them what they thought, that sort of thing. And for the most part, they really have enjoyed the program, so much so that in the current third wave, I actually still have around 11 patients from the first and second wave that have continued to go through since they enjoyed it so much. Much like the in-clinic face-to-face chronic disease support, many of the patients like the aspect of accountability, the education that's provided, and the support knowing that part of their healthcare team is readily checking in on them. We have had wonderful comments from them through the three different waves, including these two quotes. One patient said, "Knowing that somebody was checking in regularly and providing support helped me with my mental health when I was first diagnosed." And this was a patient that had been diagnosed with COPD, and she wasn't sure what life was going to look like for her with this new diagnosis. Another quote from another patient was, "This program has been an eye-opener for me. I can do things to better my health." And that was from somebody that was, if you will, a little bit flippant about his blood pressure and his blood glucose levels and these sorts of things, didn't see, you know, what it really meant for him. Something that was noteworthy is even if patients felt that maybe the program was a little bit too long, the time commitment was a little bit too much for them, they still enjoyed the program and found the value of it. On behalf of our nurse monitoring team, we have all made the time in our schedules each day of the week to go through and monitor each of the patients. And we have enjoyed taking the time and seeing the good things that have happened for patients or been able to help them out and get them where they need to be. So overall, from the nursing team, we've enjoyed and see the value in the program. Next slide, please. So what's next? A little bit of backstory. One day I was driving into work and I was wondering to myself, okay, we do chronic disease management within our PCN for these same disease processes. And typically how we run them is we do a half-hour follow-up appointment, a 1-hour initial appointment for these patients when we see them. And I was wondering how we could use this tool to improve access, because I knew that there was changes that could be made. You can customize it a little bit. I knew that there was education we could add in. So I talked to my clinical manager and my ED and Jody, who all gave me the go ahead to trial it. And then when I talked to TELUS, I found out that BC actually has a monitoring plan for diabetes that they have been using already. And it really went into depth about asking the patients information around, you know, their current diet, if they eat enough fiber, if they're getting 3 meals a day, and provided that education about why these things are important, as well as the vitals and how they're feeling on a current day. So I've been given, fast forward, I'm just a few days away actually from trialing this out within our PCN from with a couple of patients from our home health monitoring currently. And this has proved to be great timing. The PCN is in the midst of a CDM program redesign. So we're going to potentially be using this tool moving forward. I'd like to see, since, like I mentioned earlier, with the current chronic disease management program, we only see 1 to 2 patients per hour in a day. And I think with this program, we can increase that to 5 to 10 potentially, which makes access huge, and being able to reach out and help that many more people, again, with the demographics that we live in, the rural community, all of that. So I personally am really excited to see what we can do moving forward. And I've had great experiences, and see how the integration of this can go moving forward. And that is everything for me.
So hi, I'm Charlotte Thompson, and I'm the clinical manager with Kelowna Country Primary Care Network. And I have Kristen Rupert with me, and she is one of our chronic disease nurses here at the PCN. So this is our home health monitoring journey. And just, can I get the next slide, please? Just to give you a bit of history, Kelowna Country participated in the first phase, so even before wave 1, 2, and 3 in 2020 between June and September, and mainly due to physician concerns around patient care and lack of in-person appointments that were available due to COVID. And when we were approached about the project, the Vegreville physicians really jumped on board because a few of them were quite concerned about their frail elderly patients actually that had multiple comorbidities. Dr. Gupta in particular stated that these patients kept him awake at night, and he was finding that they were showing up at the ER and they were really sick by the time they actually came to the ER because they had fear of going in to see their family physician. So at the same time, the PCN nursing staff were looking for ways to do better virtual care for chronic disease patients and follow up with COVID positive cases that had multiple comorbidities, such as diabetes and hypertension. And so we took our first crack at the program. Next slide, please. And so I will turn it over to Kristen to discuss some of the steps she took at the beginning.
So for the home health monitoring phase 1 project, we had 9 patients, and that ran from June to September 2020. We had enrolled frail elderly patients with many chronic diseases and had 4 physicians participating at the Boehringer Clinic. Some positives of enrolling frail elderly was that they were very engaged, and due to COVID, were a little lonely, meaning that they were more eager to talk and share their issues via phone and to be a part of the project. Physicians received messages through their EMR weekly on how their home health monitoring patients were doing overall. But more importantly, they received immediate feedback from the PCN nursing staff if there was concerns. And this gave the physicians opportunity to reach out or change medications to the patients, to keep the patients from ending up in the ER. The downside is that the elderly patients struggled with the IT connections and remembering how to use the tablet. Nursing staff spent a lot of time trying to get proper readings and talking to support to get the tablets reconnected and getting patients to complete the evaluation documents. Overall, there was a lot of time that we had spent over the phone. So during wave 1 with 11 patients, we made some changes based on what we learned from phase 1. We decided to do younger demographics, so we picked age 40 to 70 years of age, diabetics and with hypertension, and patients with an A1C of greater than 7% and blood pressure greater than 140/90. However, the physicians were getting busier and physician engagement decreased, causing the patients to feel that their family doctor wasn't requesting the monitoring, and more patients dropped out earlier than 3 months. There were also technical issues with the equipment that caused patient dissatisfaction, and although those issues were resolved, some patients didn't wish to continue. So then wave 2, we had 15 patients, and we stuck with the same chronic disease, but used a wider range. Our demographic changed from 18 to 74 years of age. And we changed how we signed the patients on. So the physician and the patient and myself were involved in in-person meeting, which meant that we got better input responses, and patient satisfaction and participation increased with the physician engagement. We had slightly higher physician feedback, physicians impressed with monthly reports on all virtual charts, and all initial starts and signing offs were completed with in-person visits, which meant better evaluation. We also started spreading the program to 3 other physicians in the Tollfield clinic. And in wave 3, we have 13 patients, same demographics. We're still doing the in-person signups so that all initial surveys are completed. The EMR now has a smart form for physician referrals for the program, plus patients are sent with a doctor prescription for the program. And this has started the patient care plan. Patients are more involved and are completing input daily. And we're able to use the home health monitoring for the diabetic wound clinic that we have here in Vegreville to monitor sugars and blood pressures to improve the healing process. We have continued to spread the program across the PCN communities, adding Killam and Vegreville clinics for a greater response for more patient involvement.
Can we get the next slide, please? So this is our learning to fly, and we're starting to spread and sustain, hopefully, the program that Kristen and myself have found very useful in Vegreville, and spreading it to other communities. So when we went to Vermilion, Kristen actually spent 2 days introducing the program, signing on patients initially with the nursing staff there, and reviewing how the system worked on patients and on the patient end and provider end. After that was completed, the nursing staff in Vermilion actually used their EMR, where they have the direct access to the physicians, to pull lists. And the lists that they pulled were the patients that the physicians had that had a higher A1C than 8, and patients that had early diagnosis hypertension within the last 6 months. Each of the 4 family physicians were given a list and were able to review and then give the nurse back feedback as to which ones they felt would be best and benefit from the program. The nurses then proceeded to contact patients and see if they would come into the clinic and discuss home health monitoring. The girls in Vermilion were able to sign on 15 patients within a 2-week period of starting the program. They've also started to bring in their dietitian to the program, so they're able to share some resources and share referrals and care. And then the one thing that the dietitian brought up is that when she was trying to explain the program, she didn't really understand what it was about. So we started to think about having a poster to be able to spread the word and get better understanding of the program and clinic for the patients and the clinic staff. So this is just a poster that we have now that we have put into the physicians' exam rooms, and we have it in the waiting rooms, also in the PCN offices, and we've given it to each of the MOAs in the clinic and other support staff so that people have a better understanding of what we're doing with home health monitoring. The positives, the CDM, the nursing staff have great job satisfaction from this program. They feel that opportunistically talking to patients, being seen for chronic disease management or for foot care has helped them with patient engagement, better understanding, and better disease management when added to home health monitoring. In the last wave here, the third one, improvements in glucose and hypertension numbers, patient understanding of chronic disease literacy are all positive outcomes that we've seen. And the physicians in both Vegreville and Vermilion that have been participating feel that the program is worthwhile. So right now in Vermilion, they have 17 patients that are participating in this third wave. And they have, in the third wave, we also went from, instead of having to do the 90 days, sometimes we have patients on for a month and sometimes on for the whole 3 months. But when the kit comes back, we're able to get it out to another person quickly. So hopefully be able to go through, enroll more patients during this wave until December. Next slide, please. So this is just a quote from one of our patients, and I'm sure that a lot of people have heard this before. I never understood my numbers. My doctor just said they were high. So we have a couple of success stories that we'd like to share. So in Vermilion, when the girls were initiating one of the patients on the first day, her blood pressure was discovered to be fairly high at 188 on 113. Being able to message the physician in the EMR system, the girls were able to send a message to the family physician. The family physician was able to give us a change in prescription that day and initiate the new prescription right away. The girls followed up with the home health monitoring, checking blood pressures daily. And within a couple of days of the new medication change, the hypertension was decreased to 136 over 93. And as the time went on and the patient was on the home health monitoring for the full period of time, she actually reached 113 on 88. The patient now feels they are more aware of what normal blood pressure target should be, the role of medication that it plays in managing your blood pressure, and understanding the importance of doing home blood pressure readings and taking those readings to each of their medical appointments. So that was one story. The second story surrounded a patient that was also taking part in our wound clinic at the PCN in Vegreville. The person had increased glucose, had hypertension, and had a foot ulcer. The patient was being seen in the wound clinic starting in May 2021. And by July 2021, no healing of the wound had occurred. And if anything, the wound was getting worse. The physician and the nurse discussed home health monitoring program with the patient, and the patient agreed to try the home health monitoring. So when we started, the ulcer size was 0.4 centimeter by 2.2 centimeter and 0.2 centimeters in depth. After being on home health monitoring for a month and having regular interaction with the CDM nurse, also coming to the wound clinic every second week and offloading, the wound actually started to close to where it was totally healed by the time patient was finished home health monitoring. And the CDM nurse has continued to follow up with this patient over the last year, and their wound has continued to stay closed. So future programming, like
Next slide.
oh, sorry, next slide. Oh, that's what ended. Okay, so as the same as Camrose, we are looking at how we can make this part of our chronic disease program going forward, and being able to monitor patients with newly diagnosed hypertension, diabetes, and then also we would like to be able to use it for type 2 diabetics that maybe are needing to transition from pill form to insulin. The other area that we would like to focus on is our pregnant patients. Our Viking community has a lot of pregnancies that the physicians deal with, and so we'd like to maybe monitor hypertension in pregnancy. Next slide. And so we would just follow up with questions. Thanks.
Thank you, everyone, for being here this afternoon, and a special, we'll move over to questions in a moment. I just wanted to just make a couple of quick comments. So first, a special thank you to Jody, who unfortunately couldn't be here with us today, Brooke, Charlotte, and Kristen as well, for all your support, as well as the fact that all the PCNs in the Central Zone played a vital role in getting this initiative up and running, and for its success, quite frankly. Also want to thank the Health Cities team, Chris, Justin, Elizabeth on Health Cities side for all their help. And then again, just wanted to thank the other folks that are part of this, leadership from the Ministry of Health, thank you very much, as well as from the Ministry of Seniors. We've also had support, as you saw earlier, from Boehringer Ingelheim, TELUS, Alberta Health Services. So it was a great collaborative effort here, and what we're really looking to do to see if we can scale these opportunities where we see the wins, where we see patient value, and where we see the clinicians see this as an opportunity. So Justin, please keep your eyes open for questions. I see that Andy does have a question. Please go ahead, Andy.
Sure, thanks Reg, and thanks all the presenters. Andy Ridge with Alberta Health. I'll just ask a general question. It kind of piggybacks, Reg, from your last kind of comment on scale up. You know, just going through what you've talked about, the successes, etc. It seems like a no-brainer that this is what we should be doing. I'm just curious if there's any obvious barriers. Is it culture within an organization or the patient? Is it financial? Because I gotta believe that this is saving money somewhere else in the system, and so do we just need to look at the whole chain, particularly avoiding ED visits, etc. I'm just curious if there's any high-level perspectives on the number one issue we keep running into before scale up is this or that, and maybe there is nothing. It's just keep pushing with great leadership. But that's the one thing that jumps out based on what I heard so far.
Yeah, no, great question, Andy. I'll take the first stab at it. I do know that in terms of implementing something like this, something that you'd all appreciate is capacity is always an issue. Because in our PCNs, they are at the max in terms of being able to serve the patients that they do. And so trying to bring in an innovation like this, while there are savings downstream and there's value for clinicians and patients, the implementation is challenging because you're taking somebody off of the front line to do that. So that's where I think we can really use some support in terms of being able to have additional resources and capacity in the PCNs to help implement these where we have the data that shows that it's going to prove valuable. But could I hand it over to Brooke, Charlotte, or any of you to have a comment on anything else?
Do you want to go first, Brooke, or do you want?
Oh, you go ahead. You go ahead, Charlotte. I'll follow you.
Okay. So yeah, I would agree, Reg, with what you just said, but also the being out in rural area, sometimes internet connection. So being able to get patients to use the tablet and get the information back to the nursing staff was difficult in some areas. And then like what we had talked about, the physicians really were quite concerned when COVID started about those frail elderly patients that are in their homes in rural Alberta, and them not understanding the use of the equipment. And so just having to take that time and exercise takes time away from Kristen being able to provide help to other chronic disease management patients that we're trying to help as well. So it was time consuming to say the least for that part. And then you had mentioned too, Brooke, when you were doing your presentation about the limitations of the EMR. So I think being able to have that, not having to double document is huge.
Yeah.
So.
There's a question here in the chat, and I'll just read it out. It's a question to Camrose and Clina County PCN. Were there any specific KPIs that you were keeping track of throughout these cases?
Sorry, who that we were keeping track?
Indicators.
One more time. Sorry, I think my internet's cutting out just a little bit.
Yeah, I'm sorry. KPIs or key performance indicators.
Oh, I'm not sure. That's kind of a what's the word I'm looking for? That's kind of a, what do you mean by key performance indicators?
I can jump in, Brooke. Yeah, so
okay.
So the details I'd have to pull up, but yes, we have as part of this project, we wanted to make sure that an evaluation was completed so that there was some consistency across the board. So we did work with an evaluation group to ensure that identifying KPIs at the beginning, what are we trying to get to at the end, and a lot of it was around healthcare utilization, patient provider satisfaction, and some others. There has been, as I said, an evaluation completed at each stage, and then we continue to add on that. There will be a more complete or comprehensive formalized report at the end, which I think the whole point of that is to make sure that we can share that information with the broader audience, like the group here today. So we won't go into too much detail there, but the short answer is yes.
All right, thanks very much, Chris, for that. Evan, I see you have a question. Go ahead, please.
Thanks so much, and really appreciate the update on this work. I'm curious, and it kind of piggybacks off Andy's question, but, and sorry, I'm Evan Romano, ADM of Health Service Delivery in the Ministry of Health, but we're going into a meeting on Friday, actually, with the Provincial Primary Care Network Committee. So looking at the zone level approach, and I have to admit, struggle on the government side as well. And how do we have great initiatives like this that are really being led on the front lines at the zone or within zones, but at individual PCN levels? I'm wondering what you see as opportunities to share that information kind of more broadly across zones, to leverage some of the reporting that Chris spoke to, and where you see opportunity, or if some of that is underway to be able to share some of those learnings. And most importantly, then, how do we double down on our support for these initiatives, be it through resourcing for tools, looking at how we just make this part of an ongoing practice going forward. So your advice would be helpful to see how both government ministries, but also PCNs on the front lines can kind of meet in the middle.
So Jody probably would have been able to answer that one perfectly, because she's involved in a number of those discussions, Evan. I think, first of all, having partners, on the AH side or Ministry of Seniors is a good starting point for that, because then we can feed that information back so that there's an awareness on what has to change from existing policy or funding or anything related there. And then, there are lots of opportunities. We have a steering committee that includes some leadership from the PCNs as well as with AHS. And as part of that, they would hear the evaluation results and be part of those discussions. And then in addition to a number of the other groups that Jody and the Central Zone leadership team has been part of, things like this are important, because I know there used to be like the primary care, the PCN conference that used to occur, and it's probably been some time since that has happened. So we need more forums like this to share the learnings of projects like this one.
And I think Brian actually put my executive director put a comment in. So in order for us to continue this program and use it with our chronic disease patients, and I do think there's great value to having this program going forward, it's how does the PCN afford the cost of the kits to give out to patients, because we really don't have the funding to be able to do that part either.
Yeah, it's Brian Match. I'm the executive director for Clean and Country Primary Care Network. And so one of the benefits of the program was getting that time for training the nurses in the startup and the time involved in the planning and implementing. So we've got that now, and what you're talking about is, and then how to share that out. Within Central Zone, the EDs meet as a group, as Central Zone EDs with Jody, and then we have a discussion about these different initiatives and programs, and then spread across all of the PCNs across Central Zone. But really, to sustain this project, there is a question of those kits, and then also there is a cost, I believe, if we choose a TELUS platform, or if there's a different platform, IT platform, monthly cost for that. We've started to look at, can people bring their own devices, and where they have own devices or they're purchasing devices, could we look at giving a suggested price list and devices that they could potentially purchase. And the other thing I would say that would be really important is that whole connect with Alberta Health Services, and communication and connection and partnering and collaboration with the Alberta Health Services. Now, going provincially across all of the PCNs, that's a bigger challenge. And I think that would be from zone to zone at this point.
Great, thanks, Brian, for that feedback. It's very useful. So we're coming up to the top of the hour, and again, I'd like to thank everybody for your participation today. This is it's been an exciting project, and we're trying to figure out what the next steps look like here. One opportunity that's before us is some of you may have heard of the economic development arm of the federal government called WD. It's now been renamed as Prairie's Can. They're actively working with us to see if we can actually establish PCN innovation sites throughout the province with some federal dollars. And of course, their angle is really around the innovation technology side of things. But we'd also will be having conversations with different ministries at the province to see how we can participate with that, to jointly look at innovation sites in the province around PCN. So if any of you are interested on that front, would love to hear from you as we're starting to pull together these conversations. I've left my contact information in the chat. And so please don't hesitate to reach out to me. We'd love to include you into those conversations as well. And with that, I'd like to close off, unless there's any last minute comments or questions from anyone before we wrap up for the afternoon.
Reg, did you see that Lori has her hand up? So.
Oh, I'm so sorry. Yes, I don't see that. So Lori, please go ahead.
Oh, hi. Sorry, I was actually just typing in a comment in the chat, but I just wanted to add to what Brian said. It's not just about the cost of kits or supplies. So many PCNs across the province are experiencing significant cuts in funding. And so for some PCNs, we're going to have to look at our human resources available to implement something like this, because for smaller PCNs, it could be, you know, they might have to look at closing off another service or pausing a service in order to be able to do this. So you have to weigh that out. So I would say we do need funding for supplies and kits, but we also need funding for additional human resource.
Yeah, no, completely appreciated, Lauren. I think that, as I was just mentioning before, in terms of looking at the federal and partnering with the province, I think that's where we'd like to look at as well, is more holistically, not only consumables and devices, but also the capacity and human resources you're going to need to deliver this. Because if we can truly demonstrate, Andy, to your point, the value back to the system, then we need to figure out a way to do that. And I think, it gives us an opportunity to test different care pathways and see how we can influence them. Not all of them will demonstrate value, but those that do are the ones that we should start looking at how do we scale. So, Chris, if is there any other comments that you can see that we need to attend to? And if not, do you have any final comments or thoughts?
I think we're good for comments from the group, but just even the interest that we got, I think this shows the interest, the need, and the value of programs like this. I've been involved in a lot of these types of projects, and I have to say, and it's a testament to Brooke and Charlotte and team presenting. This couldn't have happened without the willingness and patience and excitement of the clinicians that are actually implementing this. So agree with all the what was said today, in terms of this being a no-brainer to continue on, and Reg, through the forums that you had said, I think there's lots of opportunity for discussion to make this sustainable, and happy to share whatever information is needed to make it easier for other PCNs to participate. So thank you everybody for joining us. This is great.
Thanks everyone. Have a great afternoon.